understand things. So when I said I use laser in here, laser therapy gets through all these tissues. In the top right corner, the main thing about laser therapy is it decreases inflammation. So as a chiropractor who I know I'm going to work the tissue, I know I'm going to put my hands on and restore function, I still want to mediate that process neurologically and biochemically until my biomechanics can take over and be restored. And at that point in time, we're creating wellness without medication. We're creating structure and function that are going to help people stay healthy or not deteriorate. Decreased problems in inflammation contributes to better blood flow. Better blood flow contributes to nerve regeneration and cartilage production. So let's look at a few things that when the inflammatory process is kicked into the spine is really crucial. Now, Dr. Dan Murphy is the neuroscience professor at Life West Chiropractic College. He spoke at the neurology conference of 2014 and presented on this stuff. His work is astronomically big and unbelievable work. Again, I'm a guy who pulls things from other people and pull it all together. The main thing to take away from this is that a stiff or fibrotic spine decreases mechanoreceptor firing to the cerebellum, the thalamus, and the thalamus, which we know is the presynaptic integrative pool to the cortex. So everything goes through the thalamus. In the brain, directly affecting sympathetic nervous system, your physiology, and hormone production. So if your mechanoreceptors aren't firing properly, you need to get adjusted. Gravity influences your physiology. The more the head shifts forward as the spine collapses, the faster you die. This was a study done by the Journal of the American Medical Association in like 1967. And it just continues to be studied again and again and again and again and again. And it's never been proven wrong. The single biggest predictor of early death was head shifting forward from the normal gravity line. Is that chiropractic, yes or yes? And by us not checking for this, if a patient comes in with a head shifted on the forward gravity line, but they don't have pain, are we under an obligation to educate them and ask them if they want to be adjusted, yes or yes? And to not treat patients with this condition when they want to be taken care of, that'd be negligence. Because death is kind of the worst side effect of anything that could go on in your body. And I get frustrated at times when I see our profession, we shrink in. We have so many amazing things, but we fight. We're killing ourselves as a profession when we talk about evidence-based versus not evidence-based. And in my mind, all we ever propagate evidence-based really means pain or no pain, right? And that's not really the mechanism. The mechanism is wellness and proper function, and pain is just one of the ways that it propagates itself. So when you pull evidence from all the people that are doing chiropractic that aren't chiropractors, we are overwhelmingly the greatest modality for healing that is non-emergency based, and the propagation of wellness should be in our hands. So this is a brain map, the 10 circles of chiropractic neurology, that if you understand this, you understand every single thing that can go on in the human body and why the spine is the master system. Essentially, when I see here that mechanoreceptors go into the layer of the spine, we just saw the video, travel up through the thalamus into the cortex, that's where a breakdown in that chain causes dysfunction. Now, right in the middle, the cortex, the first 3 cervical vertebrae, mechanoreceptors, fire the vestibular nucleus. What that means is that every single chiropractic adjustment ever done fired the vestibular nucleus of the brain stem. Whether it's an activator, whether it's a torque release instrument, whether it was a drop table Thompson or a hands-on rotary cervical, every single adjustment fires the vestibular nucleus of the brainstem. That is incredibly powerful. And this is from the Journal of Neuroscience, August 1st, 2007. We can't disprove anything we do anymore. It's only proving what we do. And now's the time for us to rally as a profession. I know so many people that want to be a principled chiropractor that go, but I'm afraid of my association and people don't back us up and we don't got all this stuff. Guess what? This is your support. This is what we do. This is amazing stuff. It's a great time to be a proud chiropractor who wants to get your hands on patients again. And not just treat pain, but look your patient in the eye and go, when I get you out of pain, if they're a new patient, I want to keep you well. And I want your family to get this, because here's why. Your children are growing up with these patterns, and when they fall and they have a little boo-boo, but the brain fires, and then their foot's turned out a little bit. After about 6 months, they're going into dance. They can't get their leg up here, but the other leg goes, and they're missing out on the dance rolls they want to get. I've seen that happen in my daughter's class. This is why it's so important for people to be regularly taken care of. So let's talk about pain inhibition patterns, because we're going to see one predominant pattern in our office all the time, and that is like a combination or a layer syndrome. So in other professions, we call it upper cross and lower cross syndrome. In my world, that's a subluxation syndrome that is being caused by all the mechanisms we're talking about. So a layer syndrome is essentially a combination of upper and lower cross. It's basically where we become too tight in the front, thereby the muscles in the back are inhibited from firing, so we lose our proper tone in the back. Our hip flexors get too tight, and our glutes stop firing for support. Make sense? So that's a crossed syndrome. Everything in the body works in an X. The neck, the shoulders, the individual shoulders. Right SI, left shoulder, left SI, right shoulder. Baseball players, they found, amazing studies, that a pitcher who has an ankle biomechanic problem is more likely to blow his elbow out and his shoulder out and need Tommy John surgery at some point in their career. From ankle biomechanic problem. Why is that? Because when they're healthy and they're growing up and they learn to pitch, they step in, they fire, and it's a proper release down the line. When the ankle biomechanics was off, they early released, biomechanically, everything's in an X. It was unstable. So think about doing any activity, gardening. I'm tight, I've been sitting all week, my hip flexors are tight neurologically and biomechanically, my glutes aren't firing anymore because I sit at a desk all day, I've had instances of back pain, I don't take care of myself, I shovel, I lift, this fires, this doesn't fire, I turn, and I gotta see Dr. Jamie tomorrow morning, which I kind of love, because they think of us, because I'm their go-to guy. But those mechanics are what happens. And that's where we work, our magic. So the majority of your patients will display some form of a crossed syndrome. And if you only worked on how I teach you to fix those on all of your patients at one time, they're going to start to get well. So lower crossed, I just talked about, too tight in the front, too weak in the back. Misfiring of the spinal stabilizers, thereby leading to an unstable disc. And we all know that flexion with load is very unhealthy for an unstable spine, yes? So we tend to pick things up inappropriately, okay? Upper crossed, this is where your patients that were leaving your office to get physiotherapy for a sore shoulder or to get something else out in their hands, instead of seeing you and you didn't even know they were leaving, is getting rotator cuff problems. They go see the doc, they get a 1.5-minute visit, they get an anti-inflammatory, and then they said, go see my physio. And they're like, well, I'm in pain, so I better go see the physio. And now they're not coming to get adjusted. They're not coming to you for the modality that you're presenting that gets rid of pain the best for laser therapy. So you get 6 months of an ultrasound machine on you. They put the suction cups on you to make your muscles that are spasming try not to spasm, but you're trying to override the brain. What did we learn about pain inhibition patterns and neuroplasticity? If I put IFC on you to break that spasm pattern, your brain's going to make the spasm pattern stronger. And then if you have a partial thickness tear in there because now you're seized, and every time you use your arm, it's rubbing under the shoulder blade, your shoulder blade stops firing, your thoracic spine becomes rigid, your heart and lungs can't breathe, and you got a rotator cuff problem, and now you're in a vicious cycle. All from too tight in the front, and the shoulder blade stabilizers were not allowing proper glide and motion in your posterior region to make that work properly. Does anybody see where I'm going with this? Is this good information, or is it all old school and nothing new? Like, are we, yes? Yeah? So now, layer syndromes are basically our old concept of chiropractic called subluxation. Our profession's trying to get away from subluxation. I got a little bit of an answer for that. Anybody ever get somebody come in their office and go, I got fibromyalgia? You're going to tell me that the basic principle that science, without a question of a doubt, neurologically, biomechanically, and at the cellular level is proven to be in existence is the vertebral subluxation complex and the abnormal mechanics of the spinal segment is not something we can embrace and patients can get, but fibromyalgia is, where we take anybody that's hurting with inflammation, throw it in a box, and then that's us. And you give them a reason not to feel good about themselves. I got fibromyalgia today. I can't move. How are you doing today? Oh, it's a bad day. My fibromyalgia is acting up. Well, what are you doing for it? Oh, I took some medications. Going to skip work today again. There's nothing they can do. The doctor says there's nothing they can do. I just got to live with it. What? This is where it's at, folks. But I'm going to give you a little bit of a different perspective. The old school histopathology that Felicia and the Renaissance group taught with kinesiopathology, nerve root entrapment, physiopathology, and chemistry issues can be looked at in a new light with SMCD, stability motor control, or TED, tension extensibility, and JMD, joint mobility or joint dysfunction, which is something that we like to write on our reports. When I was in chiropractic college, everything was a joint dysfunction so that I could get my hands on it to adjust, and the clinicians would sign off and we could work on them. Well, we know that joint mobility is going to come when there's an inhibition of a pattern. But testing for these different concepts, if we start to understand this and we start treating these with the modalities available to us like hands-on therapy, active release, functional exercises once we've done our adjustment part, and then using laser therapy to get into the joint without any side effects, helping it propagate proper blood flow, pain reduction, and regeneration of tissue, you've got the answer. So what are some of the advanced biomechanics of VSC? Well, this is where your notes in your exam. So we all got to take notes. We all got to do proper testing. But how do we do a really good job where we're complying with our requirements, write them down efficiently, and feel like we're giving world-class care while teaching our patients at the same time and showing them where it's there? So your notes in your exams reporting, communicating a diagnosis are going to be thoroughly documented and supported on a regular basis. So if we test patients this way, here's what we can look for. SMCD, stability motor control. This will show up as motor control dysfunction, local muscle function or asymmetry. So that is the person who's got the big shoulder up here and the low shoulder on this side, or they can sit up one way, or you test them, they can raise one leg but they can't raise the other. Prime mover or global compensation. This is key. Prime movers are where for instance, I said the glutes before, right? If we're going to do a squat or we're going to move, those are prime mover. But if the prime mover is inhibited by a tight hip flexor, they can't both fire at the same time. So pain inhibition would say, if my hip flexors are super tight, I'm slowly going to make my brain turn this off. If I try to make this fire in an instant, it forgot. And the longer I have chronic pain or sitting or not moving, sitting's the new smoking, that's where the body starts to break down and get disease. Poor dynamic stability, alignment, postural control, asymmetry. So we do this one. We look at them from the front. What did I say? What's the biggest predictor of death? Forward head, rounded shoulders, Dowager's hump in your seniors. Has anybody had a senior lady come in with the roundedness and they ever walked out of their office just straighter, just after an adjustment? It's amazing how fast the nerves can fire for a little bit because they were never fired. I had a woman come in. It was remarkable. So I'm doing an assessment. I'm palpating her. I'm doing some motion. And then I said, okay, I'm going to go get the x-ray machine ready. And she gets up and she goes, is he done? I feel great. And she goes to my assistant and goes, where do I pay? I hadn't even got started, but just by getting my hands. No one ever put their hands on her. She sat in chairs at doctors' offices learning about geriatric problems, getting a pill. She sat longer in the chairs at the pharmacy waiting for them to get filled. Just by palpating and introducing a bit of passive motion where she actively couldn't do it because of that, she thought she was done. I go, this is amazing. She referred 4 people. You got to see my guy. That's a Goto Chiropractor, yes or yes. TEDs, this is your tensions. This is your muscle pathology. This is your spasms, your trigger points. And what I really believe is that the fascia, I showed you a video of the nerve endings, how rich and how the chemical communicators work in the fascia. Fascia is where innate intelligence communicates. It's like the cat who always lands on its feet when it's falling out of the sky, no matter if it's spinning. It's the innate intelligence in the body that communicates through all the fascial lines that run us. Everything works in an X. All the fascia communicators run through the body. You want to take somebody who's got a radiculopathy from a cervical disc, and you want to determine if it's really just that or if there's more going on. Take their hand, put it out to the side, bend their wrist back and pull, and ask them if they feel any tingling. If they feel tingling in the middle 2 fingers, that's anterior pec fascial line. And the pec fascial line goes down through the elbow, down into the wrist, and we stretch it. Now, some people call that the T1 nerve root stretch, but it's not. It's actually fascia. Why? Upper cross syndrome, too tight in the front, too weak in the back. So that fascia is restricted. Go into somebody's posterior capsule in their shoulder and palpate just below the acromion. Posterior capsulitis. Well, the doctor said I had a rotator cuff tear. Well, your capsule's so tight, I can imagine why it's tearing. Is the problem the tear, or is it the capsulitis and the capsule restrictions? It's not gliding. It's the capsule. We have to keep in mind looking outside. So all of these different things can come from TEDs, and then your JMDs, your arthritic joints, single joint spasms. Like I said, an ankle problem that's somebody sprained their ankle, it almost fused, and they're a baseball pitcher, so now they have to adapt around it. Or someone, I had a patient the other day, she tripped in the garden and literally wrecked her ankle. It was like that movie, what's that movie? She hits the ankle with the sledgehammer. It's a Stephen King movie. Misery. Oh, I had that happen. That's what ruined my basketball career. I went up for a layup, came down, and someone went, 1, 2, 3, night, night. Boom, I was done. I was like, and then I can still lean on one ankle because it's unstable, because everything got shredded. So you get arthritis later on. You see where I'm going with that. So those things break up. Fusion of joints, so people that have had surgeries that you've never had a chance to get their hands on in time, and then they're coming to see you because they need relief. What do you do with a joint that's got rods and pins, and then they are packed, and you know that that's not moving biomechanically? Do you do some active release to keep whatever tissues are still working good? Do you laser that area, because laser is the only modality that doesn't heat metal and provides pain relief at the nerve root level, at the collagen level, at the muscular level, at the chemical level? Having some laser in your office to be an extra natural chiropractic congruent modality can provide magnificent help for patients that are coming to you that are biomechanically unsound. Diagnosis: dyskinesis due to vertebral subluxation complex. Dyskinesis, Dorland's Medical Dictionary: a reversible physiopathologic state consisting of unnoticed, misdirected neurophysiologic reactions to various agents and the repercussions of these reactions throughout the organisms. These errors in energy expenditure, which are capable of producing functional disorders, consist mainly of covert errors in the action potential output from the motor and premotor areas of the cortex and the consequences of that output. Remember the 10 circles of neurology? Dyskinesis is the effect, and it's reversible. And that's where chiropractic hands-on care, changing pain patterns, introducing proper biomechanics kicks in. So the correction and prevention of these, restoring biomechanical function, reduction of inflammation, it's the holy trinity of wellness. Because the breakdown in those systems lead further down the chain into disease and unwell. So how do we deliver this and become a go-to chiropractor? You need a world-class assessment. You need that wow your patient while you're working on them so that they know that you know. And that when you tell them this is what you need, they know that you know that you know that they know that you know. Affordable care. Nobody got better in one visit. A lot of people walk out feeling great. But if you're going to change patterns, they need care. And there's nothing wrong with prescribing a long-term course of care if you can communicate the reasoning behind it and you are certain in your mind why, and they know that you know that they know that you know. And an appointment schedule, how to give them access to your office. Does anybody like good lawyer jokes? Chiropractor walks into a movie theater, starts working on the person in front of him. Guy, what? Starts working, checks him out. Little pop, little pop. What are you doing? He goes, listen, I'm a chiropractor. I love adjusting patients. I love helping people. I just want to help everybody I can. Turns back and goes, well, I'm a lawyer. And you don't see me trying to screw the guy in front of me. Remember everything about the X factor. Everything works on an X. All the fascial lines, the spiral lines. So if I turn to the side, there's an X, there's an X, there's an X, there's a big X, and a bunch of little X's throughout the body. In the middle, we know the fascia contains nerve blood supplies and has fibroblasts and mechanoreceptors that communicate. Fascial communications body-wide is proprioception, nociception, interoception. That's from Janda. So one of the things I took from outside our profession is the selective functional movement assessment to complement what we already know in the chiropractic techniques. And this is just a powerful assessment that basically it's a movement assessment categorizing whether it's stability, mobility, or tension, or all three. So I'd like to take you through some of those and just show you basically, and what I'm going to do is I'm going to treat somebody here like they're a new patient, show you how little time it can take to be really comprehensive, take you through what I do, See if it makes sense, and it may be something that you can take with you tomorrow to go back to the office with. Is there anybody here that is a chiropractor with back pain? Would you like to be my example? Do you mind? Okay. I'm Jamie.
I'm Marie-Josée.
Nice to meet you. Okay, so what we're going to do is we're going to go through these motion patterns. So I've taken a history. I've gone through your problems. I don't want to know what you have. I'm going to look with a clean set of eyes. Now, I'm going to ask you to do some motions. I just want you to do them and tell me what you notice, and I'm going to see what I see, and we're going to put those together and see what happens. Does that make sense? Can I get your shoes off, please? Now, right off the bat, if they're in too much pain to move and they can't do a lot of these tests, this is where I'll laser them and I'll do a little bit of soft tissue and use instrument adjusting just to get them to a point where we can do a functional assessment. So we have to, put that up front. So just with your neck relaxed, touch your chin to your chest. Any pain, problems, anything you notice with that? Chin to the sky. Any pain or stiffness or tightness? Going down into the left side? Just a little bit. I turn to my assistant and I go, that's dysfunctional, painful, so DP. She could move her head, and at that moment in time, I might see her do this. How does that feel? Great, no pain. That's functional, painful, FP. Okay? Or totally functional, non-painful. So she'll write down everything I do so that all the tests are accounted for. Turn your head this way, touch your chin to your collarbone. Stiffness at all, any change?
Yes.
In the same spot?
Yeah.
Turn this way for me, touch your chin to your chest. Same spot? Okay, just bring that arm across for me. Yeah. Arm across this way. Any tightness with that? Any problems? Arm up on your shoulder. Can you do that for me? Can we switch sides? Do the same thing? How's that shoulder? Any problems with that? No problems there? Great. What I'd like you to do now, I'd like you to keep your arms nice and loose by your side. And I want you to just turn this way as far as you can. Let your hips clear. Keep your heels flat on the floor for me. Any problem with that? You feel a little bit? Okay, let's go the other way. Anything with that? Okay, now did anybody pick that up? Can you face this way and do that again for me?
Both sides?
Yeah, we're going to go this way first. And go the other way. Anybody see that? Legs given out. She goes, and I'm not picking you apart. This is what and I'll say this to my patients. I'll go, there's nothing wrong with you, but this is what I want to know. I'm going to be very, very picky because I've got to restore this. So when you go this way, you turn and you clear pretty good. The minute you go this way, your hips stop turning, now turning torso, and then when you get to this point, your leg comes up. But it's actually the hip dragging the leg or some tightness in the hip flexor or whatnot that could come from that. So I point that out to them right there. So that's important. Okay, so now what I'm going to ask you to do is with your feet together, don't do this quickly. Legs are locked. I just want you to see if you can go down, touch your toes, and come on back up. Any problems with that?
Yeah.
Feel a little tightness? Where do you feel that? Yeah. Okay, now I'm going to ask you to pick your left leg and just kind of stand on one foot. Yeah, just like that. And let's go down again. Is that easier?
Yeah.
So what I've done there is all I've done is I've unloaded the side that was sore. They instantly feel better. So in my mind, I'm saying, well, you know what? It looks like you're unstable. You can't support that. People will always say this, my hamstrings are so tight. I go, well, that's not your hamstrings because you just reached your toes. Okay, you with me on that? So then let's pick the right foot up and go down. Is that harder to do? Yeah. You're shaking a little bit. Yeah. Okay. Hands up in the air like this. I want you to lean back as far as you can and make a big banana.
Pardon me?
Make a big banana, just lean back. Is that hard to do?
No.
Is there any stiffness in that spot where you had it before?
No.
Okay, that's good. You'll see people do this. They get their arms up and they bend in the L. The hips don't clear, so they bend back and they're stuck. Ideally, you want your hips to come all the way back. Now, at that point in time, if they can't do that, I'll have them put their hands on their hips instead of up in the air. All I'm doing is loading the thoracic spine and the shoulder blades to see if the lumbar spine moves. And if I take the load off and they can do it, that means the thoracic spine's overloading the lumbar spine. Really simple, little easy test. So now the cat's meow. I'd like your feet apart like this. And I'm actually going to have you face everybody for this one. This is kind of important. So this is called the overhead deep squat. This is the absolute communication of all functional mobility, stability, all together. With your hands up like this, your feet just a little further apart, they have to stay flat on the floor. I'd like you to go down into a squat position and come on back up. And come on up. Anybody see that? Guesses? Forward, knee turn, heel slip. So you come forward because you don't like your shoulder and that neck, because that's not clearing. You have that little tightness in that left side. And because of that, when you go down, you go like this, and it moves. So that is the stability and mobility. So I want to check that a little bit further. Bring your arms across your chest. Feet apart for me. Chin up. See if we can go down. Keep your heels flat on the floor. Little hitch, a little bit better. So now I'm going to hold your hands, and I'm going to let you, I just want you to sit back. I promise I won't let you fall.
Sit back.
Sit back on your heels, just like a squat. I've got you. I got you. I got you. I got you. Come on up. Was that easier?
Yes.
Okay. So what I just did there was, I was her spine. I did what the muscles weren't coordinating the action, the stability for. Make sense? So now I say, your spine's not firing. It's not supporting you. But when I did the work that they're not doing right now, you could go down through the motions. So right now in the back of my mind, I'm going to break that out a little bit further. So I'm going to just move the laser out of the way here. Can I get you to lie face down on the table? So at this point in time, I'm going to do chiropractic checks, leg length, a short right leg, we know that. I'm going to palpate. Interesting. Your left side was tight, but do you feel that this has some give?
Yeah, it's my right, but my left works so hard.
Yes, you got it.
Yeah.
And does that feel kind of hard and locked up?
Yes.
So now I'm just going to do a simple little test. Can you keep this leg straight and raise it up to the sky for me? High as you can and down. Any pain or problem with that?
A little bit.
Okay, and then this leg? Anybody see it? Yeah. Pain on the left side, she lifts with the hiking of the hip. There's no proper leg motion. The right leg was fine. So now I'm going to make this work. I'm going to try to make this like an electrician will align the fuses, okay? With this arm just normally down and this arm straight out in front of you, okay? I want you to raise your arm up. Keep this arm up.
one?
Yeah, and push against my hand. Yeah, keep that pressure there. I'm going to hold your spine. Now raise that left leg. Go ahead, keep the pressure there. See that go straight up and then down. All I did was provide a bit of stability on that L5 disc, and she lifted her arm to do what? Activate the X. Now she could properly go through the motion. Make sense? Okay, thank you. Come on up. So this is the point in time where actually I'm going to now just say, we're going to sit down, we're going to have a talk. So I found some problems in your spine there. If she brought me a disc with x-rays or we had some pathology, we'd go through that. And I'm going to go, what I have to do is change that pattern. You can see how you got stronger. You've got inflammation in the joint. You've got stability problems. And I'm going to give you some exercises as we go along to get that better for you. We're going to adjust your spine. And then we're going to do some therapy on it with the laser to help decrease the inflammation, get that muscle healing, and getting you feeling better. And that can cut your healing time in half when we do that. Does that sound like a good plan? Can you come back on your stomach for me? So there's a bit of a report.
Oh, I go back?
Yep. You can leave your shoes on, that's fine. Watch this. So now, I would normally just tuck this under the belt. I'm going to type in 049, that's my code for lumbar. It's preset. It's on. Okay, I'm going to be back in just a few minutes. We're going to move that to the other side. It's going to go for 3 minutes, going to go for 3 minutes. Do you have any questions?
Well, for you, because you said you work in open concept. Now, if you
This
use
is a
the
private
laser-
room.
Okay.
Yeah, good question. This is in my laser room. So now we're running that. So we're going to go and talk again now, us for 3 minutes. I'm out adjusting a patient. We're going to communicate all of us again. The boom arm's doing the work. I can work on another patient. And then they're getting world-class superpulsed laser therapy, which is hitting all the pathways that are in there. So that's a way for us to go about that. And then I'm going to break it down in my report of findings, and I'm going to give you an example of a report of findings in a minute or so here. So those are the top tier tests. Now, if you do the full SFMA course, there are breakdowns, which I showed you just a couple of them when you bring your hands down and you change that. But that's a basic chiropractic exam you can do in 2 minutes almost every visit. So the X factor is its stability, mobility, tension. I always tell them in the report that I'm a pattern changer. You came in here with pain patterns. I need to change your pain. Have a look at this example. Does anybody see any abnormal patterns? left shoulder unable to retract the shoulder blade. Is that going to create an impingement syndrome? Yes or yes? Right knee, chondromalacia patella maybe. This is an athlete. And then look at the, so in consequence of that right knee, the right hip is back and the left hip is sinking. These are the little things that you can pick up, and when you show them, they're going, oh wow, this person knows what they know. So we've just gone through, some extra time. I hear the beep on my machine. I can now come over. I can change it over the next part of the disc. I can run the laser for a few more minutes, okay? When I'm done with that, Jose, can you come on up? What I'd like to get you to do now is some exercises that are going to help you loosen up your spine but fire the stabilizers. Have you heard of an exercise called cats and dogs? Okay, come on up on your hands and knees. This is a simple little exercise that takes 2 or 3 minutes. I always want to check them that they are in the vertical line. And I say, can you arch your back, pull your pelvis in like a scared cat in the cartoons? Opens up the back, which is fantastic. Now I'll go down the other way. See that little hitch? We're going to work that out. 3rd or 4th one, so go on up again. Now, she has a left side pain problem. I'm going to come in here while she's doing it. You keep doing it. I'm just going to challenge her elbow, try to make her fall over. Keep going. The brain is rewiring itself because it has to fire, and then down into the other one. Because I'm giving it a little added problem, it's called pattern assistance. We're making changes. Okay, that's great. So we're going to start with that, and that's just going to open for a typical low back problem. Can't do an overhead deep squat. Now, I know she has a shoulder problem. I can see that in the neck where it doesn't want to clear. Pretty straightforward. When I adjust the thoracic spine, I'm going to get that cleared out. Can I have you on your stomach one more time? Maybe with your head up here this time, just because oh, sorry, no, you're right, that way, because it's this shoulder. If you do this one shoulder move on all of your patients, you're going to clear most of their impingement problems. Okay? Can I bring this arm just behind your back? Does it go back there, or is it pretty stiff and sore? Okay. I just use the front of the shoulder, use the scapula, and I just start rocking it. Clockwise, counterclockwise, first ribs clearing, front, too tight in the front, clearing. The shoulder blades moving properly now. Come on up, dear, thanks very much. Now that that shoulder blade's moving, she should be able to do the next exercise I'll get into in just a bit for scapular stability. Thank you.
All done?
Yes. So, treatment, active release.